Hello, everyone. My name is Ayesha Abid. I am a second-year medical student at FAU, and our project involved looking at the danger of cardiac contusion and sternal fractures, specifically in the geriatric versus the non-geriatric population. So sternal fractures often occur as a result of a blunt thoracic trauma, and the impact to the anterior chest wall can cause cardiac contusion. However, there is limited data available on cardiac contusions, specifically on geriatric patients who were defined as the age of 65 years or older, and we specifically looked at geriatric patients with sternal fractures. Thus, the aim of this study was to compare the incidence of cardiac contusion in geriatric versus non-geriatric patients with sternal fractures, and to determine if the outcomes for geriatric patients were more severe or were worse. So we looked at an IRB-approved retrospective cohort study that included 404 patients from 2 level 1 trauma centers between the years of 2015 up until 2020 of May. The comparison of geriatric patients with sternal fractures and non-geriatric patients with sternal fractures included characteristics and outcomes. The analyzed variables included the age, gender, comorbidities, cardiac comorbidities specifically, pre-injury anticoagulation use, what was the mechanism of injury, what was the ISS, the injury severity score, what was the Glasgow Coma Scale score, was there a traumatic brain injury, retrosternal hematoma, concomitant fractures, sternal plating, ECG, electrocardiogram findings, echocardiogram findings, cardiac enzymes, whether they were elevated or not, the diagnosed rate of cardiac contusion, if the patient needed to be on ventilation, what was the total rate of each group, ICU admission rate, as well as length of stay, as well as hospital length of stay. And finally, we looked at hospital discharge deposition, including mortality. We defined cardiac contusion as the presence of both an abnormal ECG and elevated enzymes or an abnormal echo. And this was our definition for cardiac contusion. So abnormal ECG findings included arrhythmia or AV block, bundle branch block, or an ST segment deviation. Abnormal enzymes were considered if there was an abnormally high level of troponin over 0.04, creatinine kinase MB if it was over 5%, or if BNP, brain natriuretic peptide, was over 180. An abnormal echo was defined as any wall motion abnormality, the presence of intramural hematoma, or intrapericardial hemorrhage. In our results, we found that there were more comorbidities that were statistically significant for geriatric patients at 95.6% versus the 65%, and that the pre-injury anticoagulation use was higher in geriatric patients at 45.3% versus the 8.9% in non-geriatric patients, and this was statistically significant. The predominant mechanism of injury for both groups was through motor vehicle accidents, which is why when we were defining our cardiac contusion, we chose the image of the driver because that was the predominant form of injury. Interestingly, ISS scores were lower in geriatric patients at 12.1 versus the 15.2 in the non-geriatric patients. This was statistically significant. And the Glasgow Coma Scale was higher in the geriatric patients at 14.4 versus the 13.2 in the non-geriatric patients. And again, this was also statistically significant. Traumatic brain injury rate was similar amongst both groups, although it was slightly lower in geriatric patients. And retrosternal hematoma was higher in geriatric patients at 30.7% versus the 21.8% in non-geriatric patients, and this was statistically significant. Rib fractures were higher in geriatric patients versus non-geriatric patients. Non-geriatric patients had a 40.1%, whereas the geriatric patients had 50.5%, and this was statistically significant. And vertebrae fractures were similar amongst both groups, and as well as sternal plating. Abnormal ECG was higher in geriatric patients at 60.4% versus the 41.2% in non-geriatric patients, and this was statistically significant. Whereas the elevated cardiac enzymes and the abnormal echo were higher in the geriatric patients, but it was not statistically significant. The ICU admission rate was lower in geriatric patients versus the non-geriatric, and this was statistically significant. So it was 4.5% in geriatric versus the 9.9% in non-geriatric patients. And the ICU length of stay was similar, statistically speaking. The hospital length of stay included less time for geriatric patients at 7.2 days versus the 12.7 in non-geriatric, and this was statistically significant. And the hospital discharge deposition, more patients of non-geriatric were discharged home. Majority of 68.3 were discharged home, whereas in geriatric patients, the majority consisted both of them being discharged home or to a skilled nursing facility, and the rehabilitation rate was higher in non-geriatric patients, and the hospice rate and those patients who expired in hospital was higher in geriatric patients versus the non-geriatric patients. So looking at the graph to the right, you can see that there was statistical significance, specifically looking at the rate of cardiac comorbidities in geriatric patients versus non-geriatric patients. Further, there was a higher diagnosed rate of cardiac contusion in geriatric versus non-geriatric patients. There was also a higher mortality rate in geriatric versus non-geriatric patients, and the cause of death in geriatric patients was due to that thoracic trauma, whereas the cause of death in non-geriatric patients was due to a traumatic brain injury, a TBI. Thus, despite being less severely injured as evidenced by the lower ISS scores and higher GCS scores, geriatric patients with sternal fractures had higher rates of diagnosed cardiac contusion. Higher rates of cardiac contusion diagnosis could possibly be due to increased presence of cardiac comorbidities. Therefore, pre-existing cardiac comorbidities can be a risk factor for cardiac contusion. Geriatric patients should therefore be, geriatric patients with sternal fractures should therefore be thoroughly screened for cardiac contusion, as it is associated with worse outcomes, including mortality. Thank you so much, and a special thank you again to Dr. Foken, who helped us with this project, as well as to my partner, Kai, who was another second-year medical student at FAU, and Joanna, who helped us with the statistical analysis. Thank you for your time.